Hello and welcome to another episode of Conversations with Dr. Westman. This is episode number 5, where we're going to be talking about a low-carb diet and cardiovascular risk. How are you, Eric?
Great. How are you?
Very, very good. Thank you. Let's dive right in. So first question I have for you is we've all been told that, and we've all been drummed into our heads that eating fat clogs up your arteries. And I wanted to hear your thoughts on this.
Well, in short, there's really no scientific proof of that. So what is the story is one of associations, meaning this is linked with that, which is linked with that, which is linked with that. Therefore, it causes it, which is really not logical. When I was taught, in the 1980s, and when I was in training, that eating fat raised the blood cholesterol, and the blood cholesterol caused the arterial damage, atherosclerosis and heart disease and all those problems. And many people are still teaching that today. But it's I don't know the right metaphor. It's like, we're using smartphones today, not phones with cords like back then. So there's new knowledge that there's another way to go about it. So actually, I do the diplomatic sort of, maybe that might be true, but there's another way to go about it. Now, there are other scientists who are not so diplomatic and will just come out and say that was flatly wrong, that we were taught that fat causes the fat on the arteries. I'm very skeptical of that, even though we were taught that. And actually, one of the pioneering books that was helpful for me as a researcher and as a physician was Gary Taubes's book called Good Calories, Bad Calories. And I mentioned this book on a recent talk I gave, and some of the researchers said, "I can't believe you talked about a book." Well, no, this is a book about science. So Gary Taubes spent 5 years reading papers and has more knowledge about these papers than even the people who did the studies, because he read other people's papers. So in this book, Good Calories, Bad Calories, you'll see that it's a very scientific book. And in there, he tells the story of how this notion that fat in the food causes the arterial damage and atherosclerosis really has never been proven. So that was important for me. His article, I think, in the New York Times Magazine was like 2001. His book, Good Calories, Bad Calories, came out 2006 or so, somewhere in there. So, but it's still an important read if you're struggling with the idea, but we were taught that, and this is the weak observational science was being used to say that we knew cause and effect, that's just not possible. You can't prove cause and effect without an experiment. Even today on that talk panel I was on recently with the American Society of Nutrition, the story was told by a different presenter about the low-fat diet and Ansel Keys and all that. And in an evidence-based medicine program that I'm in at Duke, we use those studies as critical. We critique them and say, don't use those studies. They're not good enough. So even, when you say there's controversy, I think there's a perpetuation of the weak science, because perhaps it works in some people, phones with cords still work. It doesn't mean smartphones can't work. Right. So I can accomplish a lot using a low-carb diet and having people eat fat. But we were all taught, it's almost as emotionally ingrained as, you wouldn't go over that center line on the road, because the consequences are bad. So, and I say center line because I know you drive on the wrong side of the road there in South Africa, and I drive on the correct side. And Yeah, you tried to get me to drive in the parking lot. I seem to remember
Next
I
time
would
you'll
do it.
drive. Next time you'll drive on the left hand side.
Yeah, so but it's an emotional gut reaction, if you will, but the science really isn't there. But that's the fear of eating fat goes a long way back, and the science is weak.
What about if you eat carbs, a high carb diet, and fat? How does that affect cardiovascular health?
Well, so again, the diplomatic approach is to say, well, maybe fat is bad when you eat lots of carbs. So maybe they're right, or maybe the hypothesis is true that when you eat fat and carbs, it's bad. Well, really, the science doesn't prove that the fat is bad in that context. Just assume, we know the typical American diet that has sugar and starch, the carbs and the fat and the protein together is a bad diet in terms of the SAD diet, standard American diet, in terms of creating diabetes and obesity. How you tease out what component is the cause is not so easy, and people often see what they want to see. But I've heard that as sort of the diplomatic, well, fat's bad if you're eating carbs, and it's an easier logical step for a lot of people to take, so that I was taught correctly, fat's bad when you eat carbs, and now I'm not eating carbs, eating fat is fine. So in a clinical setting I'll use that, but purely scientifically, even then, fat is not proven to be the bad guy even when you eat carbs. It may be that it was the carbs all along, is the kind of the unanswered question. I don't think we have solid evidence of that, but there's been a sort of a taboo or a limit on the research in this direction. So, I mean, now it's becoming unearthed that the industry prevented studies about products that had sugars and starches, and almost to the extent that the tobacco industry suppressed information. And so you can create science is known as sort of a self-writing sort of discipline, if you will, so that eventually you'll find the answer, you'll find truth if you have science. Right. Well, but if you don't allow all things to be studied, then you won't ever really find the truth. So up until our study came out in 2002, from 1980 and 2002, you couldn't study a high-fat diet because everyone knew that eating fat was bad. So there was a constraint on being able to study even a high-fat diet, even though there were doctors that were using it at the time. So now, 20 years has passed. A lot of studies have been done on high-fat diets, and it looks good. But again, we're struggling with that. It's almost emotionally ingrained that eating fat is bad, and then now you can't even study it. But clinically, there are lots of different benefits that occur. I mean, we've seen that in our clinics, in the research, and the adapt events. It's pretty amazing what can happen.
What about the notion that we've all been told we have this notion of good cholesterol and bad cholesterol? Can you go into a little bit more detail in terms of the good cholesterol, the bad cholesterol? We don't obviously refer to it as this, but the layperson always speaks about this.
Yeah, well, so traditionally, we were taught that LDL was bad, low density lipoprotein, and I've heard it used clinically, or we'll say L is for lousy, to make you remember that it's bad, or L is for lethal, if you really want to turn the persuasion and fear about it. Well, it turns out there's a good LDL and a bad LDL, even if you are in the cholesterol sort of story, that the small LDLs are the bad guys, the large LDLs are not as bad. you know, Nadir Ali, a cardiologist at the University of Houston, has some great videos on what LDL does. And in fact, it's not in there to cause heart disease. It actually has beneficial effects. And, you know, the deep dive is that LDL even helps you fight bacteria and fight infections. So the more you drill down, there's a good bad and a bad, and then now, so I've even kind of, so clinical trials, we published our paper on what happens to the large and small LDLs many years ago. And in general, what happens on a low carb diet is the small LDLs turn to large LDLs. And so that's thought to be a beneficial effect when you think about changes in cholesterol. But now, since those studies and in my clinical practice, it's not 100%. So not everyone on a low carb diet has the small LDL gone. And I think the consensus that this is the only thing you think about is eroding, it's changing. And it wasn't until I helped write the book Cholesterol Clarity. Jimmy Moore asked me to help him write a book called Cholesterol Clarity. And it's basically a summary of the podcast that he did with these cholesterol experts who are doing the research but not getting their information beyond the clinical barrier or buffer. So actually the cholesterol scientists for a long time have said it's not about LDL cholesterol, you know, it's about inflammation. So the science about cholesterol is changing from good, bad, and all that to inflammation sets the scene for the cholesterol. I know I digressed. Going back to good cholesterol, that's thought of as the HDL, H meaning healthy, for HDL, healthy cholesterol, but there's a good HDL and a not so good HDL. When you look at, again, when you try it, so it gets ever more complicated as you look at this, and there are some skeptics who have kind of, you know, looked at the data in a different way and basically said none of this matters. And I'm more and more open to the idea that we're kind of talking about the wrong thing, that cholesterol is not the most important thing for cardiac risk, even though most doctors believe it is. I've even had doctors who have ignored the diabetes and the obesity, and they treat the cholesterol by not treating the underlying cause of cholesterol problem, even if that's the cause. So anyway, it gets very complicated, and you know, I can see eyes glaze over pretty quickly in my clinic patients. So a lot of times I'll just say, hey, don't worry about that, you know. But yeah, there's a good, bad. So LDL, lousy, but I wish we didn't teach that now.
Just before we move on from cholesterol, you know, from the blood lipids, how about the role of triglycerides? Because typically when we get a panel done, we get total HDL, LDL, and triglycerides. Is triglycerides a good measure of cardiovascular risk? Yes, actually there are good studies on showing the fasting triglyceride or even the random triglyceride during the day correlate with heart disease. And it doesn't get a whole lot of attention, that idea. More attention has been paid to the idea of a low HDL. And so the way I explain is that the total cholesterol and LDL is kind of the old way to look at things. I want to look at the triglyceride and the HDL and even the ratio. So triglyceride divided by HDL, the ratio of triglyceride HDL is a great predictor of insulin resistance. And now more and more studies are coming out looking at that number, it's just a ratio, correlating with outcomes. So that really didn't hit the research world until very recently. So now larger studies are incorporating that number, and it does correlate pretty well. I mean, it correlates with insulin resistance, which is thought to be the underlying, one of the underlying factors toward heart disease and diabetes, diabetes being a strong risk for heart disease.
So yeah, I would, if someone does want me to explain the lipid profile, I'll kind of cover the triglyceride and HDL and say that the old way would be to look at the total and the LDL, and we look over time. And most of the time, actually, on a low carb diet, it goes down, the favorable change. And then I'll cover up the total and LDL and say, well, the new way is to look at the triglyceride and the HDL, and we look at those trends over time. Triglyceride almost always going down, HDL almost always going up. And for the most part, that reassures people. If not, then I go to a website which has a calculator, actually. It's called CV Risk Calculator for cardiovascular riskcalculator.com. And it's a guideline, American College of Cardiology and American Heart Association guideline that you can input your numbers and get your risk for the next 10 years, your heart risk. And interestingly, when you go through that inputting of variable of your factors or your numbers, they don't even ask for LDL anymore on that. Yes. The total and the HDL. So I mean, I'll use that if someone really wants to go further and to look at the total, the LDL, the older way, triglyceride and HDL, the new way.
And so you typically see that triglycerides improve on a low carb diet.
Absolutely, yes.
Yeah.
And which doesn't make sense even to a lot of doctors. So because triglycerides are also known as fats. I mean, they're in the family of fats, and they're going around. And so even I'll have doctors who, in their mind, think the old way of fat in the food, fat in the blood, and they don't make the connection that it's actually the sugar and the starch in the food that creates the triglyceride in the blood. And the where that happens is in the liver. So fatty liver is actually from sugar and starch, not from fat in the food. And so I'll in my area anyway, doctors still make the mistake, oh, you have fatty liver, cut the fat in the food.
Right.
And no, it's the sugar and starch in the food that creates the fatty liver. Fatty liver makes the triglyceride in the blood go up. So I can understand why this is confusing. It's confusing to the general public. It's confusing to doctors. And but we just teach how it works and show by example and by having someone try it, and with measuring all of these things in a clinic, that these things do change in a favorable way.
And if you were gonna advise somebody that was worried about their cardiovascular risk, so we've obviously spoken about the blood lipid panel, which you say is not the best thing to look at, except if you're looking at triglycerides and the ratio between HDL and triglycerides. What other tests are predictable and good tests to do to predict cardiovascular risk that you could just mention?
Yeah, it was through, there's an old saying, how do you know something? Is it by teaching? No, not really, because you can just put up a PowerPoint and talk through it. It's by writing. So it's by reading and then writing something new is how you really learn something. And in the book Cholesterol Clarity, I had to kind of make the call of this question: what do you measure? Well, don't measure the predictors. Measure whether you have the disease or not. So actually, the disease you're trying to prevent by the cardiometabolic risk factors, looking at cholesterol in the blood, is arterial disease in the neck, the heart, the artery of the abdomen called the aorta. And in our area, actually, you can get these measurements by ultrasound. It's non-invasive. Ultrasound is the same technique used on babies, to look at babies grow. It's safe, no radiation. So I advise people to follow their own arteries, not the prediction of whether you have it or not. And it works really well for those who are in the prevention mode. You know, you don't want to use predictors. If your arteries are clear, you don't have the disease. You don't have to prevent the disease that you don't have, right?
Right.
So another commonly used, and it's even in one heart cardiology guideline in the U.S., the coronary calcium score. It will give you an idea of whether you have coronary disease, but it doesn't show you the artery directly. Again, it's kind of a predictor of whether you have it. These ultrasound measurements show you the artery directly. Now, this concept falls down if you do have, say, moderate disease. Then, you know, should you make a change to reduce? So the way I look at whatever you've done, it's smoking, it's blood pressure, it's diabetes, it's diet as well. If you don't have the disease, don't change what you're doing. if you do have the disease, then you might want to consider making some changes, but monitor the disease, not just treat risk factors. And there's a whole, you know, business, a whole intellectual approach to treating cholesterol in the blood. In fact, a lot of doctors will resist checking the arteries because they think there's a perfect correlation between the predictor in the blood and the disease, and there isn't. It's not a perfect correlation. And then drug companies get involved with selling products that, you know, have some benefit but not much. You know, it turns out you have to treat 100 people to save, you know, one person from having a stroke, for example, in some clinical settings. So most people who take a pill don't really have any benefit from these things, but we have doctors who are taught that that's the right way to do things. We have guidelines that say if you don't do it, you're out of line, you know. So that gets complicated too. So I just kind of teach, here's what you're trying to predict, this disease. You can actually measure it, you know, get someone else to measure it for you. And that's what you should follow, not predictors anymore. And, you know, 20, 30 years ago when I was in training, we didn't really have access to these types of measurements so easily, so widespread. So it would kind of make sense that you would only use a predictor of it. But now we have access to measuring the disease directly. Why wouldn't you?
I got you. That's excellent advice, and we should all take heed and follow that advice if we're worried about our arteries, and if they are in fact clogged up and have fat running through your veins, then you can go and check that out. Another quick question before I move on to the questions that people have asked is, can a low-carb diet cause heart palpitations, arrhythmia, and AFib?
Oh, no, I think that may come from, there was a study a year or two ago that was this kind of big epidemiology study where they categorize people as by what they say they eat, low carb, moderate carb. And there was a slight increase in the study when people say what they're eating, of people who ate 30% carbs or less, 30%. So keto is like 5%.
Yeah.
So it was like a broad range of what low carb meant. And there was a study, you know, I have to think, I didn't talk to the researchers about that. Sometimes I meet them at meetings and get to pick their brains about it. But there are some people who get what's called palpitations, meaning some skipped heartbeats the first week or two. And it's part of the keto adaptation, the keto flu. I wish it was called keto cold because it's pretty mild and most people don't get it. But some people do get palpitations. I'll get, you know, an occasional email, you know, I'm having skipped heartbeats. I just reassure people, you know, unless they have heart disease and, you know, have that, then I get more worried. But I reassure people that it's a transition of fluid shifts that are occurring when you stop eating carbs. Your body gets rid of the fluid. You have a water loss, a diuresis, water loss, and that can cause a temporary, transient skipped heartbeats. And I know a lot of
That's
people worry about it, but it's something that is temporary. I've treated a lot of people with heart disease through the years, and on low carb diets and on high carb diets, people get atrial fibrillation. So I have to say this is not the perfect cure for atrial fibrillation. It's kind of like people get into car accidents whether they eat carbs or they don't. It doesn't mean the low carb diet caused the car accident. And we're at that stage where if you have something that happens regardless of the diet, to know if it's more common, we're going to have a comparative study. Study people who are eating carbs and not in a controlled way to see if the occurrence of it is any more frequent. So I don't think, in my experience, I don't think this is the cause of it. I think it happens, the kind of AFib in that bigger epidemiology study. I think life causes these things, whether you eat carbs or not. But I think that's a good place to shine more research on. If I had a magic wand and could do all sorts of research, one of the first studies I do is in people with heart disease and diabetes. Let's follow them, compare them to a group that's not doing a low carb diet. In fact, we could do a Mediterranean or other type of diet and see what happens, to see if these things happen at a greater rate, a greater frequency than other types of diets.
Dr. Westman, thank you so much for your words of wisdom. And I'd like to move on to some of the questions that we have. So I've got a question here from Daryl, and he asks, is it a fallacy that eating red meat daily is bad for you? Or has this been debunked in today's science?
It is a fallacy that eating red meat daily is bad for you. Or I wouldn't say fallacy, I'd say it's not.
The science is not showing this.
That's right. So the same kind of epidemiology science that led toward the restriction of fat in the food is what leads people to say you shouldn't eat red meat. Nutritional epidemiology, where you ask people what to do, what they've eaten, often, every few years you ask them, and then you make correlations. But there's an interesting new epidemiology study being done out of the university in Canada, McMaster University. They're doing a big epidemiology study of diet and health, and they're not finding the same findings that the Harvard nutritional epidemiologists have found. So it's causing a stir. So if you do value that type of information, it's now contradictory. And again, that kind of gets to you can see what you want to see in those kinds of studies. So I don't worry about eating red meat every day. I tell my patients it's okay if you like it. You don't have to eat red meat, but you certainly can.
Thank you. Tim has asked, if I had plaque in my arteries, would a low carb diet be able to minimize future risk or even be able to reverse it?
Well, the best study we have so far is a 2-year study out of Israel, where several different types of diets were used, including a low carb diet. Now, it wasn't as low as keto, so I kind of hold out that it might even do better. But a low carb diet led to a reduction in the arterial thickness in the neck. It's called carotid intimal thickness. So, but when you look at it, all of the diets worked. So as long as people lost weight, their blood pressure went down, and they followed the particular diet program. So I think there are lots of ways to do it. A low carb diet is another appropriate way, although studies like this don't tell you what will happen to you. So I still believe in the clinical assessment of people. There's no one size fits all. It's possible if you ate a low carb diet that it wouldn't get better. So monitor with any kind of disease or prevention of a disease. You want to still measure things that we typically measure. Don't just put your head in the sand and say, you know, Dr. Westman said it was fine.
Right.
I still believe that we should monitor these things, and you know how you feel, and then metabolic, you know, blood or imaging as needed.
Fantastic. Well, that's all we have time for today. So thank you very much for your time again. If you enjoyed this video and would like to see more posts from Adapt Your Life, you can find us on our YouTube channel, our Instagram channel, Facebook, as well as Twitter under the name of Adapt Your Life. If you're following us on YouTube, please would you subscribe and hit that notification bell so you'll be alerted to every time we post new videos, which is once weekly and sometimes twice weekly. And if you got any value out of these videos, please would you share and follow and like these videos. That would mean the absolute world to us. And on behalf of Dr. Westman and myself, this is us signing off of Conversations with Dr. Westman until next week, where we are going to be talking about being able to monitor the successes along the way. So from myself, thank you very much, Dr. Westman, and we'll be seeing you next week again.
Great, my pleasure.
Thank you.